For people who know they never want to have another child, sterilization is an option, and both male sterilization and female sterilization are available. Male sterilization is an office procedure done under local anesthesia, and many family doctors do vasectomy. It isn't just done by urologists. It is generally very well tolerated, but shouldn't be trusted until about 2 to 3 months after the procedure, when a semen sample demonstrates no viable sperm. Female sterilization can be done either by tubal ligation or tubal occlusion. For the tubal ligation, this can be done laparoscopically, or immediately after pregnancy, it can be done through what's called a mini laparotomy, which is a small opening in the abdominal wall. And with either of those surgeries, the tube is physically cut, the lining is cauterized, and there may be a clip or a clamp placed along the tube. There is also an option for transcervical sterilization, which was marketed under the brand name Assure. This was marketed as something that could be done in the office by an OBGYN doing hysteroscopy. But I have found that many people continue to do that in the operating room, which didn't reduce the cost compared to sterilization compared to tubal ligation as much as people had hoped. And I don't think Assure is being used as often as it was in the late 2000s, early 2010s. We're now moving on to methods that require use immediately preceding intercourse. So while we as providers might think this sounds very inconvenient and fraught with peril, these methods can be really favorable to some people. The diaphragms I have available are the old style diaphragms, which were round cups available in a variety of sizes. The patient who wanted a diaphragm would come into the office, and we would do a bimanual exam to test the depth of the pelvis. And then based on that, we would recommend the diaphragm that seemed to fit behind the pubic bone best for that patient. We would then leave the patient with that diaphragm and give her a chance to put it in, walk around, and practice putting it in and out. We would then return and check the fit for the patient with the diaphragm in place. The fitting diaphragms have this hole in them so that the patient wouldn't be tempted to take that one home. And then we would clean and sterilize the testing kit. The patient would have a prescription for the diaphragm in the fitted size and would be able to fill that at a pharmacy. The more modern diaphragm that's available does not require fitting, it's just one size fits all, but it does need to be assessed for fit in the office by a provider. And I haven't had somebody ask for a diaphragm more than once in the last 15 years. I haven't seen them used as much, but they definitely are still available. There is also a cervical cap available, which is a single size. This is not recommended for use after childbirth, but the cervical cap fits in the pelvis. Just like the NuvaRing, it's placed inside the vagina, and the patient makes sure it's fitting around the cervix. And she then, when she's ready to use it, would cup her finger around the ring and bring it out. For either the diaphragm or the cervical cap, a spermicidal jelly needs to be used, and a certain amount of jelly is applied inside the dome of the cap or the diaphragm, and then additional jelly is applied around the rim of the device. The device is put into place before intercourse and then can stay in place for a few different episodes of intercourse, but then it would be removed at least 6 hours after the last episode of intercourse. These devices work by creating a physical barrier between the sperm and the egg, as well as by using the spermicide, which disrupts the motility of the sperm and kills them as well. Internal condoms, or male condoms, have been used for thousands of years. Modern condoms are typically made of latex or of some other device, some other material for people with latex allergies. They are easy to carry around. They need to be used every episode, a new one for every encounter of sexual intercourse. They have the benefit of preventing sexually transmitted infections as well as preventing pregnancy. They often have lubricant or spermicide or both applied directly to the condom in the package. The package will have an expiration date. This one expired in 2015, so I wouldn't recommend using this one. Before intercourse, the condom would be placed on the erect penis. The tip of the condom is pinched to prevent an air bubble, and then the condom is unrolled over the penis. It should be tight-fitting so that semen doesn't escape from the condom. And then after intercourse, it's carefully removed and discarded. I have many patients who have successfully used condoms consistently for years and have timed their pregnancies exactly when they wanted them to be. So condoms are a really great method of birth control. And I trust people who say that condoms work for them. If they break, emergency contraception is available, as discussed earlier, and is a great choice to help prevent those unexpected pregnancies. The external condom, or female condom, was designed to give women control of a barrier method that prevents sexually transmitted infections. And it's also an option for couples where erectile dysfunction might make it difficult to place a male condom. The female condom has 2 rings, one of which floats loosely inside the sleeve of the condom, and that ring is folded and placed inside the vagina behind the pubic bone to hold the condom in place. This condom is not going to be tight around the penis of the penetrating partner. And then again, a single condom is used for each act of intercourse, and after intercourse is complete, the finger is hooked underneath the ring for the condom to be removed. Female condoms are not made of latex. This one is nitrile, I believe. It doesn't say what it is, but it does say latex-free. In addition to its use with diaphragms and cervical caps and condoms, spermicide can also be used on its own, and it is available in several different delivery methods. I have a few available here. This is a contraceptive gel. It comes preloaded in a single device for each use. The gel is within this syringe. This plunger is placed in the syringe device, and then the spermicidal gel is dispensed directly into the vagina prior to intercourse. Another option is a spermicidal foam. This also comes with a vaginal applicator. And the foam is dispensed directly into the applicator by pressing down. So once the appropriate amount of foam is in the applicator, that can then be placed in the vagina as well. Spermicide is also available as a suppository or a film, which would be placed in the vagina about 15 minutes before intercourse, where it would be able to dissolve and be effective. The sponge is another spermicide delivery device. The sponge is placed directly in the vagina over the cervix, where it will absorb the semen and prevent transmission of live semen into the uterus. It needs to stay in place for 6 hours after intercourse is complete, and then it's removed by pulling on this loop of fabric. The sponge is actually much less effective in women who have had a baby than in women who have never had a baby. Lactational amenorrhea is actually an effective form of birth control. There is decreased fertility immediately following birth because the normal FSH and LH cycles have not resumed. And these cycles are delayed further by exclusive breastfeeding. This is why women often don't get their period when they are breastfeeding and not giving formula. Once people start replacing breast milk feedings with formula feedings, the breast isn't getting stimulated by the infant suckling, and there is more likely to be an LH surge that would trigger ovulation. So lactational amenorrhea can be trusted if the woman is exclusively breastfeeding, ideally not even giving bottles of pumped milk very often, if she has not yet gotten her period, and if the baby is less than 6 months. If those conditions are in place, lactational amenorrhea is as effective as the combined oral contraceptive. This is a flowchart that helps a woman determine if she is a candidate to use lactational amenorrhea. And you can see that this basically says just what I just said. In withdrawal or coitus interruptus, the penis is removed from the vagina before ejaculation occurs. Ideally, this would mean that no sperm were able to get up the vagina to the egg. However, there can be some pre-ejaculate that would contain sperm, and this also requires partner control. This is, again, like condoms, something that many couples will use effectively. If it works for them, then I don't negate that. I have definitely seen couples who have timed their pregnancy using withdrawal as their primary contraceptive method. Fertility awareness involves tracking the menstrual cycle and using one's knowledge of when ovulation occurs to avoid intercourse during the fertile window or to use barrier methods during that window. Different methods for fertility awareness are more effective than others. The basic premise is that the standard menstrual cycle is 28 days and that ovulation occurs 14 days before the menstrual cycle, before the menstrual period. So really, a period follows about 14 days after ovulation if the egg is not fertilized. Different people have different lengths of menstrual cycles, but a single person is usually consistent within her own cycles. So if she knows her cycles are 32 days, she could count back 14 days and then avoid intercourse during the week around ovulation. Fertility awareness is more effective if you use the symptothermal method, which means taking a basal body temperature every day, ideally at the same time immediately after waking, because after ovulation, the temperature will go up by about 0.5 degrees. You can also follow the characteristics of the cervical mucus, which changes as fertility increases. So by combining those methods and charting the menstrual cycle, people can often know when their fertile window is. Some people, instead of using charts and the cervical mucus, will use ovulation predictor kits. A lot of people will do this just when they're trying to time pregnancy because the kits can be pretty expensive, but they also can be used to prevent pregnancy as well. There are smartphone applications available to help with tracking most of these methods. There has generally been a provider-focused perspective that the best contraceptive is defined by efficacy. So there has been a perspective of really pushing the long-acting reversible methods because we can see that they're so effective. This can lead to patients feeling like their autonomy is being threatened. I think it's important for us to include these in the options that are available and to provide them for our patients, but to also understand that there are many reasons that someone might not want one of these methods. They might not like the idea of having a foreign body inside of them. They might really hate needles. Some people want to avoid hormones at all costs. There's just a lot of different factors that might be involved. So listening to our patients and asking open-ended questions can help us direct our care as best as possible. I'd like to mention the 1K question, which has been suggested as something that we should ask all women of childbearing age at every office visit. I'm not sure that I am at the point of doing it at every visit, but it's a great way to think about managing reproductive health. We ask the patient, would you like to become pregnant in the next year? If the answer is yes, then we provide preconception counseling, including reviewing medications and medical history for anything that we might be able to modify before pregnancy to reduce risk to a developing fetus. And we recommend taking a folic acid supplement. If the patient says no, we check whether she's happy with her current method of birth control, and we might provide a different method if needed. But someone might also be somewhere in the middle. They might say they're unsure, or they might say they're okay either way, in which case we could provide more nuanced counseling that meets the patient's needs. If contraception is desired, I'm recommending moving away from giving a menu of options where we go through every single option like I just did. We're unfortunately taught like this in medical school, and then we think that this is how we should teach patients, that we have all this information in our brain, and the right way to teach a patient is to give a brain dump of all this great stuff we learned, and then the patient will figure out from that what works best for them. We can actually be more patient-centered and more efficient if we use open-ended questions to narrow down what we want to give a lot of information about first. So we could ask the patient, do you have a sense of what you're looking for in a contraceptive method? If someone says they want something that's as effective as possible, then we don't need to talk about the diaphragm, and we can just talk about long-acting reversible methods. If somebody says they really want something that will also help with acne, then we could talk about the combined oral contraceptive pill. If somebody says they really want to avoid hormones, then we would focus on those methods. We can also ask questions like, what do you know about this method? Or what have you heard from your friends? Because a lot of people will have preconceived notions of what might be good or not good for them based on the experiences of their friends or family members. There's a concept called the righting reflex, which is our instinct to provide corrective information if somebody says something that we think is not scientifically true. And we'll hear this with contraception, like, I really don't think it's safe for me to not have a period. A good approach to this is to find a kernel of truth in what they're saying, such as, if you're not on a hormonal contraceptive, we would really want to look into why you might not be having a period if that were to happen, because it could be a sign of something else going on. And then we can give some additional information that we want the patient to have, such as, in patients taking the contraceptive pill, we know that the lining of the uterus gets really thin, so it isn't unsafe at all to not pass a menstrual period. In fact, it's normal. And some people really appreciate the opportunity to avoid having a period. When I'm talking about the long-acting methods, I will describe them as effective for up to 5 years, or up to 7 years, or up to 12 years, so that the patient really knows that they can work that long, but they don't have to work that long. And I specifically say, we can remove this in 7 years and place a new one right away, or we could remove it at any time if you decided you were interested in becoming pregnant or if it just wasn't working for you. I want people to feel in control of their contraceptive method and know that I'm there to work with them to help them with that. If you want more information, you can find pretty much anything you would want to know about contraception in this great textbook, Contraceptive Technology. If you want more information about women with medical conditions and what contraceptive methods might be safe for them, the United States Medical Eligibility Criteria for Contraceptive Use is available online, and there's also a smartphone application that you can download that can get you that information at your fingertips. The Reproductive Health Access Project has put together a lot of resources for clinicians, including quick start guides and information about what we can do to prescribe different contraceptive methods. And they have my favorite patient user guides. So I have a lot of their information as dot phrases in my Epic account, so I can give that to patients when I give them their contraception. For example, a pill user guide that tells them about doubling up if they miss a pill. Bedsider is a really great patient-centered resource, and sometimes I'll open this up and use it to help guide my patient-centered contraceptive counseling right in the office. If you think of other questions that I haven't covered today, please send me an email and I'll see if I can answer them the best I can. Thanks for sticking with me. Good luck.